All right, let's dive right into a super important area for nursing students and practicing nurses, non-inflammatory bowel disorders. We're going to break down everything you need to know about hernias, irritable bowel syndrome, and intestinal obstructions. Think of this as your ultimate study guide to make this stuff crystal clear for your exams and your shifts. So, here's our game plan for today. We'll start with the absolute basics. Then we'll do a deep dive into hernias, IBS, and intestinal obstructions, one by one. After that, we're going to shift gears and focus on how this all connects to the NCLEX and clinical judgment. And to wrap it all up, we'll finish with a quick clinical challenge to test your skills. Let's get into it. Okay, so the three big disorders we're hitting today are hernias, IBS, and intestinal obstructions. Now, why are they all grouped together? Because they're non-inflammatory, and that's a really important distinction you need to make. We're not talking about Crohn's or ulcerative colitis here. These conditions are all about issues with structure and function, not chronic inflammation. Let's kick things off with hernias, and the subtitle here really says it all: when the bowel breaks through. You can pretty much think of a hernia as a mechanical problem, a breakdown in the body's structure that we as nurses have to be ready to spot and manage. So what exactly is a hernia? Well, at its core, it's when the bowel gets pushed out of place. I want you to imagine your abdominal wall is like a strong, muscular container. A hernia happens when there's a weak spot in that container wall, and a piece of the intestine actually bulges through. It's kind of like an inner tube poking through a weak spot in a tire. And this can happen in a few different places, like the groin, the belly button, or even along an old surgery scar. Now, this is where a simple hernia can turn into a serious crisis. And you need to know the difference. An irreducible hernia is one that's basically stuck. You can't gently push it back in, and that means it needs a surgical evaluation. But a strangulated hernia, that's a whole other level. This is a true surgical emergency. The blood supply to that piece of bowel is completely cut off, and the tissue can start to die. When you see the signs, sudden pain, fever, a racing heart, vomiting, those are massive red flags that mean we need to act immediately. So who's most at risk for getting a hernia? Well, it kind of depends on the type. For example, indirect inguinal hernias are much more common in men. Direct hernias are often tied to getting older, but a huge risk factor for almost all types is anything that increases pressure inside the abdomen. Think about the constant strain from a pregnancy or obesity. That pressure can literally force the tissue through a weak point. And of course, incisional hernias can pop up as a complication from a previous surgery. After surgery, our job is all about patient teaching. We have to make sure this doesn't happen again. So it is absolutely critical that patients avoid anything that increases that intra-abdominal pressure for about 2 to 3 weeks. That means no deep coughing, no straining to have a bowel movement, and absolutely no lifting anything over 10 pounds. That's about the weight of a gallon of milk. We'll also tell them to use ice to manage the swelling, and we'll push fluids and fiber to prevent constipation so they don't have to strain. All right, let's switch gears and move on to our next topic, irritable bowel syndrome, or IBS. Now pay close attention to the subtitle here, the functional GI disorder. This is the whole key to understanding IBS. With this condition, if you were to look at the bowel, it would appear perfectly normal. The structure is fine. The problem is with its function, how it works. So IBS is this chronic disorder that just messes with how the bowel is supposed to work. This leads to this really frustrating cycle of symptoms like diarrhea, constipation, bloating, and pain. And the tricky part is there isn't just one single cause. It's more of a complex puzzle involving a bunch of different factors. Things like stress, hormones, your genetics, and even certain foods can all act as triggers that make the symptoms flare up. And you've got to know, IBS isn't a one-size-fits-all diagnosis. It really shows up in two main ways. First, you have IBS-D, where D stands for diarrhea. This is where diarrhea and that feeling of urgency are the biggest problems. Then you have IBS-C, where C is for constipation. For these patients, the main battle is with constipation, straining, and that awful feeling of not being able to completely empty their bowel. So how do we manage this? Well, a lot of it comes down to medications that are tailored to this specific type of IBS. For IBS-D, we might use something like loperamide to slow things down. Now, there's a more powerful drug called alosetron, but it's a big deal. It's only for females, it's used as a last resort, and it comes with a serious warning. It can cause ischemic colitis, so you have to teach your patient to report any bloody diarrhea or new abdominal pain immediately. For IBS-C, we use meds like lubiprostone and laniclotide that basically work by drawing more fluid into the intestines to, get things moving along.
Okay, on to our third and most urgent topic, intestinal obstruction. Like the slide says, this is all about when the passage is blocked. This is a true GI emergency, and it requires some really sharp assessment skills and quick action from us.
Obstructions really fall into two main camps. First, you've got a mechanical obstruction. Think of this like a roadblock. Something is physically blocking the intestine. It could be scar tissue from a past surgery, a tumor, or even a really bad fecal impaction. Then you have a non-mechanical obstruction, which we often call a paralytic ileus. This is different. The road is clear, but the bowel itself has just lost its muscle tone and stopped contracting. It's lost its peristalsis. We see this a lot after patients have had abdominal surgery. Okay, pay close attention here because knowing the difference between a small bowel and a large bowel obstruction is absolutely critical, especially for your exams. A small bowel obstruction hits fast and hard. You'll see a lot of projectile vomiting, and it can even smell like feces. This leads to really severe fluid and electrolyte imbalances, and this is key, metabolic alkalosis, because they're losing all that stomach acid. On the flip side, a large bowel obstruction is much more gradual. The main thing you'll see is major bloating and distension in the lower abdomen, but vomiting is less common. So burn this into your brain. Small bowel means rapid, lots of vomiting, and alkalosis. Large bowel means slower, lots of distension. One of the main things we do for a bowel obstruction is put in a nasogastric or NG tube to decompress the stomach and bowel. And our nursing care here is so important. We have to maintain intermittent suction as prescribed to make sure we don't damage the stomach lining. We're constantly checking that the tube is in the right place and not clogged. And since the patient can't eat or drink, we have to provide oral hygiene all the time, like every 2 hours, to keep their mouth from getting super dry and uncomfortable. And of course, we're always monitoring their output, their vitals, and their skin. All right, you've got the core concepts down. We've covered the pathophysiology. Now let's really pivot and talk about how you're going to apply all this knowledge on an exam like the NCLEX, using that clinical judgment model. Here are a few little memory anchors, kind of like cheat codes for your brain to help you lock this stuff in. For small bowel obstruction, your brain should immediately go to vomiting and alkalosis. For a large bowel obstruction, think distension and acidosis. Always remember that alosetron alert, ischemic colitis is a serious risk. And finally, know this vocabulary word, obstipation. It's not just constipation, it means the patient can't pass any stool or gas. It's a classic sign of a complete blockage. Let's walk through how this works using the clinical judgment model. Okay, step 1, recognize cues. Your patient has high-pitched bowel sounds, they're projectile vomiting, and they haven't passed gas. Step 2, analyze cues. You start connecting the dots. What does this all point to? Well, these findings are screaming small bowel obstruction. Step 3, prioritize hypotheses. What's the biggest, most immediate danger here? It's the risk for severe dehydration and electrolyte imbalances from all that vomiting. And finally, step 4, generate solutions. What are you going to do? You're going to make the patient NPO immediately, get ready for an NG tube, and start prepping IV fluids. See how it all flows together? Okay, time to put it all together. You've done the work, now for a quick challenge. Here's a clinical scenario. Read it, put on your nurse thinking cap, and decide, what would you do next? Okay, here it is. Your patient is 3 days out from a colon resection. They're telling you they feel more and more nauseous, and their stomach feels really bloated. You listen, and you hear those high-pitched bowel sounds just above their belly button, and you realize they haven't passed any gas for over 8 hours. What are those alarm bells in your head starting to tell you? So based on those very specific cues we just talked about, what is your single most important #1 priority action? What is the very first thing you need to do? The #1 priority, the very first thing you do is make that client NPO. Nothing by mouth. You absolutely cannot add more fuel to the fire by putting anything else into a system that is clearly blocked. After you've done that, you get on the phone and notify the provider immediately with a full report. Then you start thinking ahead and anticipating the next steps, which will almost certainly be inserting an NG tube for decompression and getting IV fluids going to correct those imbalances. And that brings us to the end. I just want to leave you with this one thought. The gut never lies. The signs and symptoms your patient is showing you are telling a story. And your sharp assessment skills are the first and honestly the most important line of defense against a potential GI crisis. Thanks for sticking with me today.